Sure.
Thank you, my lady. Can I ask you on a very brief topic? When did the National Care Forum first become aware of the possibility that patients being discharged from hospital would be discharged to care settings?
I don't know exactly when we were involved in some of the discussions about it. I obviously know the dates when the various bits of guidance came out. There may well have been discussions previously at the national group about it and about the implications of that, and some of the things that we would have certainly been advocating needed to be put in place before that was possible.
But you think it was ahead of the guidance?
I think it would have been part of a discussion, yes, but not in a kind of I'm sure there would have been discussions because that was part of that. Yeah.
Can you say whether it would have been as early as February or not?
I don't recall.
Okay. Do you think if you had early notice of that possibility, that there would have been any practical measures that your members
Absolutely.
could have put in place? And
yeah.
What do you think those would have been?
I mean, I think when there were, some of the things, we produced something post the guidance and post the discharge, which was something that was framed as sort of tips for providers about hospital discharge, and that included the sort of things that they should be advocating for and that were necessary about, having sufficient PPE for somebody during the period of isolation, obviously testing prior to discharge, having access to the correct clinical and community health support that people might need, and ensuring that people's ongoing health needs, because I think that's a really important part of the whole discharge discussion, is that people were clinically fit in the sense they didn't need hospital treatment, but it didn't mean they didn't need ongoing health treatment. In fact, most people within care settings have some generally fairly significant ongoing health requirements.
Yes.
In care settings have that.
Thank you. Last main topic, it's on ventilation, please.
Okay.
Is it right that in April 2020, you had an expert called Eric Fuster come and do a report, I think, following which he produced some materials on ventilation? And if you want to turn it up, Professor, it's tab 11, his report in your bundle. I don't think we need to bring it up on screen.
Yeah.
But just to summarise, is it right that he advised that it was important to understand that natural ventilation, for example, opening doors and windows, may not provide the ventilation rate required to significantly reduce airborne transmission risk, even in the summer?
Yes, that's part of his report, yeah.
He went on to say that when windows are closed in a shared communal airspace, the only reliable way of reducing the risk of airborne transmission is to install a mechanical system of some sort. This could be a ventilation system that brings in fresh air to the room and extracts stale air, and/or a recirculating HEPA air filtration system.
Yep.
And he went on to say that if such a system wasn't available, then even if it was winter, you would still have to open the doors and the windows.
Yeah. I mean, I think we engaged the Eric Fuster because he was demonstrating some expertise in this area, and members were concerned about what was happening. I suppose the point that this talks to as well is that the care settings that people operate within, care homes, are very, very different across the country. There's some, old stately home care homes. There's very small purpose-built homes. There's ones which allow for cohorting and zoning and all sorts of different things. They're not a universal approach. And so what we thought, by bringing Dr. Fuster and his expertise in, he could talk to members to help them to work through what to do. I think we're obviously not going to get a chance to talk about all the different funding that came through, the very kind of sporadic funding that came from government, but that it is of note that it wasn't till the very last infection control fund that there was any funding that providers could possibly use for this very area of CO2 monitoring or HEPA filters. So any action that providers took prior to that, and that last tranche of funding, I think, was towards the end of 2021, was done by themselves with their own intent. It wasn't supported by government in any way to do that. So,
and he advises, in terms of long-term strategy, that there are whole building improvements that could be made. Yep. But he acknowledged during the pandemic that those weren't realistic in the short term. Yep. And so he advised things like PPE and good infection control measures yes. to be put in place. Do you know what the position is now, Professor? Do you know if any changes have been made in, for example, any building regulations or anything like that in relation to ventilation? And are there any practical recommendations that you would invite the inquiry to think about when it comes to ventilation of care home buildings?
Yeah, so I'm not aware of any changes that have been made in relation to ventilation or in the building regulations in relation to that. There have been some made in recent years in relation to fire, but not particularly in relation to ventilation. I think that there are, definitely action that could be taken in terms of thinking about how, back to my sort of central tenet, I guess, that social care is a public service, and if you want the service to be delivered in a safe way, you have to think about what the state's role is in that. So there are many other examples of other types of services where the state has made a kind of significant investment in the built environment, like homelessness and housing services. And so if we're to look towards a different model going forward in the future of a built environment, then I think that there's clearly an opportunity for the government to think about how it invests in that in a meaningful way. Much of the stock, I think there's sort of some recent survey by Knight Frank talked about that much of the stock being over 40 years old. So it isn't that there's a lot of new purpose-built provision in the environment. So if you want to retrofit filtration, or if you want to create an environment where future build has that in place, we need to have some clear direction and some support to deliver that.
Thank you. Could we move on to something a bit more positive? So is it right that National Care Forum produced an e-book called Caring in COVID?
Yes.
And can you just tell us briefly what that was, please?
Yes. So we produced the Caring in COVID book. It's a collection of stories primarily from the first wave of the pandemic, which is showcasing the kind of activities that members of ours did during the pandemic, and it's across a variety of themes. So there's a strong focus around visiting and how people supported people to stay connected with their relatives and loved ones. There's a focus on the kind of things that staff did in order to ensure people remained safe. Some very heart-rending stories of people who went and lived in greenhouses in their gardens so they didn't come near their families, or stayed within care settings. People who worked to support the broader community, so potentially they thought about how they could engage, and people who were supported by the community too. And I think it's really important that there's a recognition that, whilst maybe there wasn't as much national attention from a perspective of on what care was there to do, local communities really recognised some of that and were very supportive and helpful. So it's a great collection of that, and we wanted to have a record of that, because we knew that as time went on, it's an incredibly painful period to talk about, but people are amazing, and we wanted to celebrate some of that.
Thank you. And just to take one example, the inquiry heard in the impact film that there were some people, for example, with learning disabilities who couldn't read or write, and so they were very much reliant on human contact. And I think one of the stories in the e-book talks about one particular individual who was struggling with the lack of contact. And when they introduced the virtual contact, social contact, there's a record of that particular individual kissing the iPad.
Screen, yeah, and I think this is, I suppose that was the other point, is to actually just, and you would expect me to do this from my position, but I was completely overwhelmed by how creative and positive and responsive people were to try to make things better for everybody. So again, that level of, you're going from a scenario where only 20% of organisations had digital care records. There was low levels of digital literacy within the care sector. There was often poor Wi-Fi and challenges in that context. And people invested in all of those things. They brought in iPads, they brought new technology, they fashioned pods, they created garden environments to allow people to have as much interaction and connection as possible. And I think that's an important part of the story as well. Thank you.
And finally, Professor, are there any other recommendations that you would like to discuss today?
Yes, yes, there are. I think there's an overall recommendation which is about the urgent need for reform of the sector. We've had multiple papers, policy positions, etc., looking at this. We went into it in a very difficult position. 5 years later, we're still in a very difficult position. So I think there's things about workforce, absolutely, a workforce strategy that properly recognises the skills and expertise and the new skills and expertise we want those workers to deliver in the future, and obviously the funding that goes with that. We've talked a lot about data, digital and buildings. Those all we need to look at what that is to be fit for the future and have a kind of strategic plan to develop that. And finally, something about a kind of recognising the professional kind of expertise of the social care sector as equal partners when decisions are being made, and that's at a local level, a regional level and a national level. I suppose my sort of ultimate message is that we need those decision makers to think about social care first. It's not Cinderella, it's not the handmaiden of the NHS. It's a vital public service that's the backbone of communities, and we forgot that then, and we must never do that again.
Thank you very much. My lady, those are all my questions.
Thank you, Ms Young. Mr Weatherby, just there.
Thank you very much, and good afternoon, Professor. I ask questions on behalf of the COVID Bereaved Families for Justice UK, and I have just one topic and a few questions. It's an important topic. It's DNA CPRs, which, as you'll appreciate, is a very traumatic topic for quite a number of the families I represent. On the 26th of March 2020, you emailed Ros Rawton, who was then the DHSC Director of Adult Social Care, following contact from one of your care providers. And I wonder whether we can just put the email thread up. It's INQ 466452, and I think it's your tab 18.
Thank you.
And it's up on screen now. Can we have page 3, please? So 26th of March. And you're sending this, as I say, to Rosamond Rawton. Mm-hmm. And you say that, Ros, we've been contacted by a care home provider in relation to a flurry of emails and letters from their local GPs, essentially requesting that all residents in the home are put onto a DNAR. In one of the emails, which I know is not the scanned copy, there is even a suggestion that the GP is following government guidance stating that all over 70s in homes should be issued with a DNAR. This is a very urgent situation that could escalate very quickly and unhelpfully, causing lots of fear and concern amongst residents and their families, made worse by the fact that people are being asked to make decisions about their family members who they may not even be able to see for the last couple of weeks, nor do they have any prospect of seeing. I'd like clarification ASAP if this is in any way endorsed government policy. And then it goes on. I won't read it all. And then finally, I'd be grateful if you could also let me know the response. I think these things are probably happening all over the country. You then sent later the same day, in fact, going up to page 1 of that thread, please, the bottom half, to the same, well, to a CQC person, but also copied to Rosamund Rawton. Sorry, I've lost my reference. Just give me a moment. Sorry, you sent another email in the afternoon, bottom of page 1.
Yeah.
Further letters come through on this issue, headed sample of GP letters. The penultimate paragraph says this, quote, "We will also be signing forms to say that if your heart or breathing stops, the carers will not resuscitate you. There will not be ambulances available to continue any resuscitation or take you to hospital, so that will not work. You would be unconscious quickly and not be aware that this is happening to you and not be in any pain," unquote. The homes are being asked to give this letter out to all residents in the care home. Apart from this being extraordinarily upsetting letter for people to deliver to already vulnerable and anxious residents and families, it is essentially telling people that they will be left to die. Where was the decision to ration resources in this way made? And then you continue in terms of community health and the CQC. Just two points arising from that. Your emails suggest that there were multiple GP practices involved. Are you able to help us in how widespread you understand this issue was at the time?
So on that day that we had received note that there was a flurry of emails. Yes. So that was the description. That I couldn't quantify that anymore, but I was aware from talking with other colleagues in other organisations like my own that they were also aware that other groups of people had received. Yeah, so
not an outlier. But a flurry.
It was. I think it was an early, a bit like I was describing earlier, an early indication of something that we wanted to stop before it got more. But it was not. This definitely not the suggestion. It was one letter alone.
No, indeed. And you say, as I've just read out, I think these things are probably happening all over the country. And is that because the accounts you're receiving were coming from different areas?
So the provider I was talking about was a national provider, so they were reporting it was from different parts of the country.
Yes, thank you. To your knowledge, who was instructing, if anybody, who was instructing GP practices to put DNA CPR notices such as this in place?
I never had any answer to whether there was any instruction around that. And in fact, what happened as a result of this is we quickly did work with the Care Quality Commission and the BMA and I can't remember who else was signatures, but we put together a statement.
Yes.
To
That's my last point. I'm going to take you to that if I may. It's I think it's your tab 19. It's INQ 398629, and it's page 7. So, as you say, within a very short period of time, this is the 31st of March, you and others, and you say the RCGP, the BMA, and the CQC got together a joint statement. It's set out there in your email. And I won't read it all out, but it sets out in very clear terms the importance of having personalised care plans in place, particularly for people who are elderly, frail, or have other serious conditions. And it sets out what we've heard over and over again in this inquiry about the importance of the person themselves, if they have capacity, or the family, and them being individually put forward. And it finishes, it's unacceptable for advanced care plans with or without DNAR forms completion to be applied to groups of patients of any description. And I think, again, we won't go through the thread, but on that thread there was some discussion about whether it should be made even tougher,
Yes.
that joint statement.
Yeah.
But that was put out in an attempt to bring an end to
Yes.
what was apparently a...
That in the end, that was we were happy to go forward
Yeah.
on the basis of expediency.
Yeah. And knowing what you know, was the statement, in your view, strong enough?
I think that was the last time
Yes.
I heard of that situation. So,
Yeah.
yes, I think it's a very good example of that, but it also, I think, is, the mechanism from my memory was that the surgery had sent this to the care home and asked the staff to deliver that message.
Yes.
Bearing in mind this is potentially against people who've only just been discharged into the care of
Yes.
that home where they have no relationship
Yes.
with the relatives.
Yes.
So I think the impossibility of the task and the inappropriateness of it combined was our urgent need to act.
So you, as an organisation, identified the problem, brought it to government's attention, got together a consortium of people
Yes.
to put forward a strong statement in an attempt to do
Yes.
something to stop it. Do you think there's a risk of a similar practice happening in the future, and what needs to be done now in terms of avoiding it if that's the case?
I mean, I think that I suppose I've mentioned about the sort of need to have social care as part of decision making. So I think this is in. I suppose we read this as a kind of clinical response to a situation rather than a response that focused on people, and that's, I think, where social care can add huge amounts of value. So I think having we talk a lot about an integrated health and care system, but often that means an integrated health system delivering to
Yes.
care. And I think going forward, and we've just got the 10-year plan launched today, we'll be looking at that very closely to see if it actually means meaningful integration.
Yes.
So that would be one bit of it. And I think the other the other way going forward is to have a much there's an ambition for a shared care record. I think very clearly having a care record that moves when people move, goes with them, would mean that their sort of wants for themselves or their guardians' wants for themselves are clearly articulated.
Yes.
And cannot be overridden without permission.
And finally, we heard yesterday the suggestion that there were various rumours during the pandemic about things which may or may not have happened. In respect of this problem, DNA CPR, you're clear, I think, certainly from this correspondence, that there were blanket decisions being made, at least at that point.
Yes.
Thank you very much, Professor. Thank you.
Thank you, Mr. Weatherby. Ms. Foobster, who's over that way.
Thank you, my lady. Good afternoon, Professor Rayner. I represent John's campaign, the Patients Association and Care Rights UK. At paragraph 6 of your witness statement, you explain changes to the CQC regulatory inspection regime during the pandemic. And you highlight some concerns, including, first, that the regulator was slow to act on serious concerns about clinical practice and decisions relating to social care. Second, the suspension of on-site inspections. And third, the move to a risk-based model for inspection and regulation. And you also explained that outdated ratings caused issues for providers accessing insurance cover and in securing public sector contracts at crucial points in the pandemic, and in many cases are still causing issues. Do you agree that proper regulatory oversight should have continued during the pandemic? And if so, what more should the CQC have done?
Yes, I think that the points that you've raised were absolutely the things that we were concerned about. I think in the context of what proper regulatory oversight would look like did need to change, probably because of the prevalence of on-site inspections. I think our experience of working nationally with the CQC was different to the local experience of providers. So some providers would talk positively about their relationship, their ongoing engagement with their local inspector, and that that was helpful for them. It wasn't universal, it wasn't across the board, but that was helpful for them. I think nationally we saw that there was probably more that could have been done to identify, utilise their data, for example, to identify trends and issues, and to be more public about some of those challenges that they were seeing. There were lots of, we knew that there were lots of data coming through which talked about any breaches or anything like that. So a bit more sort of oversight of that and bringing that forward would be helpful. I think there's a very large support from the provider sector about what good regulation is. I think you're right to say that we believe that there's challenges continuing and ongoing, and we certainly in part of my role in the Care Provider Alliance have been focused in on reviewing the CQC and the changes in regulatory regime it's made subsequent to the pandemic.
And visitor restrictions removed other eyes and ears, which played a role in ensuring good quality care and identifying inadequate care during the pandemic, including not just family members, but also visiting professionals like GPs. How did that impact on the rights of people who live in care homes, including to access the healthcare they needed?
So I think we were very active working with colleagues in John's campaign and other organisations around visiting restrictions to try and do as much as possible to bring more visitors back into services, and equally trying to ensure there was better access for community health services and access to physios and others. I believe that we need to do much more going forward to balance those risks that were identified in the pandemic. So we spent a lot of time kind of measuring those markers of infection, but not looking as much at the kind of markers of isolation and loneliness and getting that balance right from a human rights perspective. So I think that the absence of visitors and the absence of visiting professionals changed the dynamic of a home, absolutely. And I think that is things that, I hope people feel that once restrictions were lifted, there's been a welcoming back in of both people and those professionals.
Do you agree that the CQC should have a duty to monitor compliance with legal duties, including human rights and equality legislation and guidance, including on visiting and risk assessments?
Well, the CQC, my understanding is the CQC framework is built around a human rights framework, so it does have a strong focus on human rights within it. I think in the context of the regulations that have been introduced since the pandemic around visiting, I think that it's an important part. It's back to what are we going to value, and if we need to make sure that if the regulator is looking at areas like visiting, we're also at the same time capturing why that's important, so that when or if another pandemic comes that puts at risk roles like essential caregivers, we've got the evidence there to demonstrate not just that people have complied with allowing visitors in or whatever the detailed regulation, but that actually we are really clear what difference that makes to the ongoing well-being of people. We've got the data, we've got the information, we can evidence it, and we can show how somebody's well-being is impacted by not having visiting, and so we don't have to have, we don't lose that relationship as swiftly and rapidly and for as long as we did during the pandemic.
And final question. At paragraph 3.2H of your witness statement, you refer to Care Act easements. What was the impact of these Care Act easements on people needing care?
3.2
H.
H. Sorry, I'm struggling. Can you say me?
Sure, I 3.2H.
It's just the question is,
yeah.
you refer to Care Act easements. What was the impact of the easements on people needing care? You deal with that general term?
Yes, of course, yeah. So the impact, I mean, I think part of the easements were something that we, obviously monitored where easements were happening in different parts of the country. But I think that the part of the reality of the squeezes and the decades of kind of austerity prior to the pandemic meant that the overall implementation of the Care Act as a whole has not been fully achieved in lots of parts of the country. So the impact of bringing in easements at that point will have exacerbated for some groups of people the challenges that they were facing already. I think in terms of sort of lack of access to assessments and those other areas, we're in a scenario where currently we have long backlogs of people accessing assessments. I think it's part and parcel of an overall lack of value of the importance of social care to people in terms of living the fulfilling lives that they need to have, and the willingness to sort of bring in easements rather than perhaps some of the other changes that might have properly funded, for example, people's ability to isolate or buy in HEPA filtration or whatever. I think it is, there's a story that needs to change about how people's care is valued at both a national level and in the public's perception.
Thank you,
Thank you,
Professor
Ms.
Rayner, my lady.
Professor, that completes the questions we have for you. And please don't worry if we haven't covered something in detail. I will obviously make sure that I read your written statement very carefully. And, of course, have an opportunity to make some closing submissions at some stage. I don't know if that'll be you again, but wherever you are, be you in the witness box or over there, you are an excellent advocate for an excellent cause. Thank you very much.
Thank you very much.
My lady, the next witness is being taken by Miss Shatunde.
Thank you. Sorry we've kept you waiting for so long.
And repeat after me, if you could get a bit closer to me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence that I shall give
shall be the truth,
shall be the truth,
the whole truth,
and nothing but the
and
truth.
nothing but the truth.
Nothing but the truth.
Lovely.
Thank you.
Thank you so much.
Shatunde.
Reverend Hardy, you may be seated if you
Thank you.
wish. Reverend Hardy, thank you for coming today to give evidence. I understand that you're happy for me to call you Reverend Charlotte today.
That's fine. Yeah.
Thank you.
Thank you.
Thank you for coming to give your account of your experience nursing during the pandemic in care homes. If I could just start briefly with your professional background. You qualified as a registered nurse in 2009. You spent some time on wards before gravitating towards care home nursing, and you had a particular interest and specialism in end-of-life care. and became a mentor for the Queen's Nurse Aspiring Leaders course. You then went on to qualify as a registered healthcare chaplain, and you stopped working in care home nursing. You then started working part-time as a receptionist/patient advisor in a GP practice, alongside parish curacy as a trainee vicar. But at the moment, you're not working currently, are you?
No.
No. So during the pandemic, you worked in a number of different roles. When it started in March 2020, you were working as a charge nurse in a nursing home. You then left that role in April 2020, undertook a role as ambulance control, but then missing patient-facing care, you decided to go back into nursing.
Yes.
Thank you. Now, you remained as a nurse in that nursing home until June 2021, and then you left that role due to the impact that the pandemic had on you. Is that correct?
Yes.
We're going to go on to that during this evidence. But before we do, I would just want to start briefly to discuss government guidance.
Okay.
Because, of course, during the pandemic, the government issued a number of different pieces of guidance on different areas. How did you receive guidance from the government?
So if I go to the first nursing home I was in during the start of the pandemic, I think most of us relied on the daily address. I think what was difficult is that the daily address would happen, and then we would get to work, and we'd be expected to have put into place things that may have come up on the address, which then, as a care home, we would then be catching up a bit on, oh, this has been announced to the public that this is going to happen. And then if there are measures to be put in place, we would feel like we would be a bit behind sometimes.
And so you weren't given any advanced warning of guidance before it came out, were you?
Not to my knowledge, no.
What do you think may need to change if there was another pandemic in the communication of guidance to care homes?
I think, so with social care, guidance to social care sector should be on par with acute NHS. Acute NHS and community NHS, they should be seen as concurrent service providers.
In other words, guidance that's targeted to the social care sector, just as opposed to just handing the social care sector the guidance that goes to NHS. Is that what you mean? And at the same time?
Yes. So yeah, yeah. So equity of communication to be paid to each.
Thank you.
And just to talk about the types of homes, nursing homes that you were working in, were they both in respect of older people, people with complex needs, those sorts of conditions?
So the first home I was in was mostly people living with dementia, and some with long-term neurological conditions, so Parkinson's, strokes, that sort of thing. The second home I worked in, unusually but not uniquely, we had a person in there with complex needs, 24-hour needs, which needed one-to-one nursing care over the 24-hour period. So that isn't a norm for a nursing home.
And with that second nursing home, I understand it could cater to up to 21 residents,
Yes.
Is that correct?
Yeah.
Yes. So just generally, in respect of guidance on infection prevention and control, such as visiting, testing, isolation, PPE, those sorts of things, did you find that they helped or hindered in your attempt to keep those residents safe in nursing homes?
So if I go back to my first nursing home, so guidance came out quite quickly, and So, for example, wearing masks, when to wear them, how often. And I remember in the first home, we couldn't keep up with, we couldn't put our hands on materials, masks and things as efficiently as we wanted to, because in that sector we weren't used to. We had loads of aprons, but masks were a main issue. But our home were quite creative. We were all quite creative in trying to source products from other means, other businesses, even a local university, and even to the point of sheets being assembled. And I remember seeing 2 seniors in the home making full aprons as a just-in-case.
Were they making them with the sheets?
Pardon?
Were they making the aprons? With
Yeah,
the
so we made so that they could then at least be washed, because then the next worry was, okay, masks are an issue. What if gowns are going to be a supply problem as well? Obviously, bin bags only go so far. So we made things that could be washed, essentially, and that was probably more geared up to, again, with that patient group being quite vulnerable. People with neurological conditions often have swallowing deficits and cough a lot anyway. So we were prepared for a full, just in case, for spraying.
And I understand you did not have plentiful supply of masks when wearing masks became mandatory.
No.
In your statement, you mention things that you and your colleagues used to do to try and preserve the mask during lunchtime. Could you just describe that, please?
Yes. So when mask wearing was mandatory, continuously, as it should at that time, we didn't have enough products, so we were then suggested, we had those little self-sealed Tesco bags that you put your lunch in. So we'd have the same mask, and then we'd put that into our little bag, seal it, have our lunch, and then put it back on. But then the confusing thing was the minute you touch your mask, you have to get another one. But, we just had to make do with what we did, and so that's what we did. Yeah.
And I understand you had training on the donning and doffing of PPE, is that right?
Yes, so donning and doffing, that's something that's not uncommon in care homes anyway. That's actually that's part of mandatory training. But obviously it was re-emphasised because of the frequency of donning and doffing and appropriate dressing.
Yeah. You speak in your witness statement about there being a stark difference between the PPE that you would wear, or care home staff would wear, and the PPE that external professionals would wear coming into the home. Could you just describe that for me? Perhaps maybe the funeral directors, for an example.
Okay, so that was in my second care home. So that was January of 2021 was when the care home became a hot zone because of multiple infections. So during that time, we still wore the surgical masks and aprons. Getting hold of FP3 was difficult. We did at one time have a small supply of the FP3 masks, which was just for one particular patient, the intensive care patient we had. But yes, so we had this, and at the beginning of that period of when I was living in, so any hospice or other clinicians visiting the home, which they didn't do very often, they initially started off, they would come in and put aprons and everything on. Then as time went on, as I was living in, my window to the outside world became whoever came to the door. So as funeral directors came, the first lot would arrive in their suit and tails, and then they'd put on their apron, gloves and things and come and collect. And then that sort of progressed to suited and booted in their white hazmat. And I'd watch them dress outside, come in and then get undressed outside. And then further down the line, when we had another hospice visit, which was a bit of an SOS from my point, then that staff were wearing full apparatus. That's the only thing I can, with the head mask and the respirator, with the visor, something from like a CBRN, a chemical, nuclear, And I think what was startling about that is not only was I watching the progression of PPE being worn, but I think for me personally, I then realised that they were suiting and booting to be protected from me, because I was then living in the home, and that was quite stark, that they're being protected from me.
And so when those visiting professionals would come in those forms of PPE, what were you wearing and the other staff?
A plastic apron and a surgical mask.
That's it.
Yeah.
How safe did you feel in that PPE?
Not much. Yeah. It was a funny thing because I was living there 24 hours a day. So the only time it really came off and stayed off for a bit was maybe at night, when I put my nightie on, kind of thing. But otherwise, I had, PPE by my room, everywhere. And it didn't feel great. There were times when I would double mask, wore short sleeves. My uniform would be washed every day. But no, it wasn't great. But then it got to a time where there's so many people infected, patients, so many staff were and had left, that for all I knew, all of us could have been infected. So it was quite strange.
Mm. So you mentioned living in the home. That's a period in January 2021 when you decided to stay in the home. Is that correct?
Yes.
I'm going to go on and talk about that experience that you had, that locked-in arrangement, in a bit.
Yeah.
But if I could just start talking a bit about the residents.
Sure.
We were just talking about PPE.
Yeah.
You mentioned that you were in homes where there were older people with neurological conditions, people with dementia.
Yeah.
What was the impact of you and other members of staff wearing PPE on those particular residents?
The main barrier, because residents were used to us wearing aprons and gloves for personal care, but the mask was a real issue, because people living with dementia or dementia process, they rely a lot more on your face to communicate, even when they have sensory impairments, sight and sound, they need to see something. And in fact, a lot of us nurses wear bright lipstick so that even when their sight's impaired, they can see, your mouth. And then suddenly having that, your face blanked out, must have looked like, it was like a horror story, I think, for them initially, because they couldn't see you. And that created a lot of distress for them. We'd even try and draw lips sometimes on there, but I don't think that really worked. So it would then mean that we would need more time and reassurance, which became more staff intensive, to try and reassure and settle residents. And we'd use our eyes and eyebrows. We really trained ourselves to speak sort of above here, so that we could communicate. But it made it really difficult for them and for us, because when people living with dementia are further confused or isolated, they can become distressed, tearful, lonely, which then affects the staff because they care for these people, but also more time is invested in settling, which is very difficult when staffing resources are already shrinking quickly.
So those residents were distressed by the PPE that was being worn.
Yeah.
You also mentioned isolation as well.
Yes.
I'm going to come on to discussing visiting restrictions, for example.
Okay.
At the beginning of the pandemic, I believe when you were in your first home,
Yeah.
you guys decided to put a stop to visits at the
Yes.
beginning. And you stated that you could see an impact that it had on the residents. What kind of impact did it have on them?
Confusion, and it would be things, even when it's not clearly articulated, people who work in care homes with people with dementia become really skilled in picking up the cues of behaviour. So that sort of behaviour we could pick up was that the residents couldn't understand why they were in their own room and they were left there, they felt left there. Why is nobody coming to see me? Frightened. Some we've thought, is it a punishment? Where is everybody? Why have you done this to me? Lonely, and tears can happen, and even frustration, shouting, help. And one person shouted help so loudly that a policeman walking by stopped in to see what was happening. There wasn't anything happening, but, so as well as the distress of the home, it would, and us in it, and the residents, when you have a home that's in a busy town, people do hear. And it sounds horrendous. Can you imagine hearing, help me, whoa? So that was an added stress to the residents, their families, and us, very much.
And there were some communal areas in the home, is that right?
Yes.
But at some point, they were closed down.
Yes.
Did the residents have an opportunity to socialise with each other at all in any other way?
So again, depending on the guidance, and there was various, 2 meters and things. So we would try and do if you like, a communal rota, where some residents could come into. We had quite a long sitting room, fortunately, and we could put gaps between people. And that way they could actually see another human for more than an in and out in their room for something. So, yes, we would try and do like a rota of socialising, social distance, as best we could. Yeah.
And then when it came to visits from family members, you'd mentioned in your statement about government guidance, and you mentioned it earlier, about it coming in quickly with no warning. But in your statement, you specifically mentioned guidance in respect of visiting and how difficult it was to deal with that without any advance warning. Could you just tell us a bit about that?
Sure. So in my second home, so by this time there had been a lot of guidance going on about no visiting, then some visiting, specific, so end of life visiting, and lots of recommendations, and also lots of rumour, because people in groups hear rumour. But the one particular thing that was very difficult was we recall an address being made that, yes, families can go into the home. I mean, we were already doing guided visits anyway, but families can go into the home more regularly with these things put in place, the testing, putting the visitor into like an airlock or a specific place, room, for visits to happen. So, and this can happen on Monday, I think it'd be something like that. So we then get lots of calls, naturally, from residents, families, saying, oh, when can we come in? When can we come in? We hadn't had time to build an airlock. And a lot of these homes are old, big old buildings, and you might not have a particular room. So luckily in this particular home, we had such a massive front door area that we built an airlock with a door in and things, so that people could come in, have their testing, wait the time for the result to come through, dress up and come in. But the distressing thing would be that as a registered nurse, we often carry a mobile phone with us. So when we're on call, when we're on duty, doing drug rounds and everything else, we were getting flooded with calls from, quite rightly, families. When can we come in? When can we come in? And just not yet, because we haven't built it yet. So that would be an enormous burden on them, but also a lot of time taken up for us to explain that, yes, this can happen, but we just haven't done it yet.
How did that affect the relationship between the care home staff and the families?
It could put a strain on it, because care home staff and families build up really good relationships over the years. And when they're tough, there's always a work through. But then when families just want to be with their loved ones and they just hear this public address, oh, but it's law now, we can do this, then for staff it becomes it then becomes a tension, because we can't deliver. And we're trying to keep relationships good, but we can't do what you want when you want it, because this address has gone out. Before we've had time, we didn't have an advance warning or anything. So it could become really strained. And in small places, some families talk to each other and, well, they did, that's not fair, and yeah.
You say in your statement that amongst families there were mixed feelings about how the home should respond in respect to visits. You said some wanted visits and others wanted a stricter lockdown.
Yeah.
And the tough work of mediation fell on you as staff. How did you approach the difficult task of balancing the competing interests of families and the concerns about infection prevention and control?
So if I use an example from the second home with that, so factors taken into consideration are how much staff do I have here? Because obviously when people come and visit, you need to have staff off the floor to do the testing and all that sort of stuff. But equally, of course, we want families to come in. And not only that, it's really helpful having someone else in the room with their loved one, because it means that we know they've got eyes on, so we can respond elsewhere. But every family, when it became to the time when the home was hot, it was infected, I would then risk assess every visit to each situation. So, for example, one person had a downstairs room with their own back door access, so their family could come round the side of the building, round the back, into the room, job done. Other family would, and if it was nice, we could do all the testing and stuff there. Others would come through the main into the airlock, and I would then, when it was just me as the only nurse, I would then risk assess their visit. Who are they seeing? Why are they seeing them? How can it be accommodated? And I took a lot of that on myself as the registered practitioner and the senior person in the home at the time, to make sure that the family and the patient had the right care. And sometimes it would be, if staff got afraid at this particular time, 2 people coming in, I would, against that sort of animal, it's that group behaviour thing of panic, of explaining that, look, we're letting funeral directors come in under guidance, and it's the same way with allowing this particular family to come in. They're being guided in, going through the same routine for them to visit. So risk assessing each visits, and eventually some of the staff got really worried about infection coming into the home and so on, but we did the testing, we did all the right things. But when I use that analogy of, well, we're letting funeral directors in, we're letting, other community practitioners in, we're doing the same thing, I think once that sort of got into mind, okay, then I had buy-in, and then they weren't sort of disappearing and leaving me to facilitate. I think once they got that, then they were can do, and then we could all work together. But fear is such a huge driver, and misinformation, especially people in groups.
Yes. You discuss an infection spike in January 2021 and still ensuring that end-of-life visits took place.
Yeah.
In your statement, you say that these end-of-life visits were the most sterile end-of-life visits you've done in your entire career.
Yeah.
Now, you recall a visit that took place where a resident died 2 hours later.
Yes.
Could you just tell us a little bit about that, including how you facilitated that visit?
Sure. So that visit, very similar to the scenario I was giving just now, actually. So the daughters, in this example, came in, did the testing and the waiting and everything, and I took them up to see their loved one. And I'm an experienced nurse with death and dying. We can never give an exact, hours or days. We can usually give like a spectrum of time. But with COVID could be really quite quick and malevolent sometimes. So when these people came in and we went upstairs and they had their time, the patient dying 2 hours later, I didn't think it would be that quick. So it was just things like that, having to constantly update clinical thinking of visiting in good time, not too late. It was really difficult. What was the original bit of the question? Have I just gone off on a tangent?
You've told us everything.
Oh, okay. Sorry, I'll do that.
Thank you. We're now going to move into the locked-in arrangements, which happened around the same time in any event. The home had managed to avoid an outbreak until January 2021, when there was a new variant. In your statement, you state that 95% of the home's staff were off work because of COVID-related absences. And you state that you arrived on shift after the 4th long day you'd done in the past 5 days, and you were told you are the last nurse standing.
Yeah.
How did you feel at that moment?
The days leading up to that day, I'd started to feel panic and fear rising as people were dropping off. And those days leading up to that, every time I looked at the rota, it was like a Harry Potter thing where things just disintegrate in your hand. Every time I readjusted the rota, it just disintegrated, and there were less and less and less. So when I came in that morning, and that night nurse was, just give me a minute.
That's okay. There's some water there if you need some, and some tissue as well. Okay, so
So I can carry on.
are you sure?
Absolutely. I've come all this way. Okay. So yes, so that was already building up. So when I came in and that night nurse gave me the night's handover through an open window outside, the first thing was I was absolutely furious that she had to be outside. She didn't have to be outside. That was so undignified and ridiculous. Then came the realisation of there's no more nurses left. It's just me. And that was quite an adrenaline kick.
There was around 20 residents, weren't there?
There were
Sorry, how many?
20.
around that. Yeah, that was boof. And I suppose in a way I knew that it was a thing that could happen. And then when it did, it was a cross between like, oh, okay, decision's been made now, but also fear and disbelief a bit.
And it wasn't just care staff and nurses that were not there. There was no management in the home. There was no housekeeping staff as well. There was one person to run the kitchen, and there was no cleaner or laundry service, was there?
No.
So did some of those tasks fall on you?
They did, and in nursing, the basics are always, they're not basic, they're fundamental, which is clean, infection control, nutrition. When the housekeeping staff weren't there anymore, who's going to wash the sheets? Who's going to wash the clothes? Who's going to keep the house clean all the time? Well, we were already sharing that bit, and that was just like, boom, that's gone. They're gone. And no nurses, except for me. Boom, that's gone. Kitchen. Thank goodness the guy stayed in the kitchen and came in every day. That was the only consistent thing. At least we all got fed. But every time a staff member tested positive and had to go home, I just remember like a little piece of me would be lost each time. Of, oh my God, how are we going to look after these people?
So in those locked-in arrangements, you stayed in the home for 10 days straight, is that right?
Yeah.
And you were providing 24-hour clinical care during that period. Now, you mentioned earlier the resident who had complex care needs and required one-to-one care, and there was no one else, just you, wasn't there, having to deal with all the 19 other residents.
Yeah.
You spoke to your husband,
Yeah.
called him and told him what was happening.
Yeah.
He gathered some things for you and brought them. You were there thinking about what's going to happen, how you're going to treat the patients, etc., etc. How did you go about with the treatment of the patients and the care needs?
I think so leading up to me saying to my sick manager who was at home at the time, leading up to the moment when I said to them, I'll live in, I'll stay, and the relief that I heard was quite sweet from them. On the run up to that, I remember just gathering as many resources as possible. I knew I couldn't have people physically with me, but the Royal College of Nursing and the Queen's Nurse Institute comrades was really important that I had that backup, that background, psychological and professional backup. So when that decision had been made to stay indefinitely, I called my husband, and I knew he would be upset and cross. And he would like, well, why is it always you? I said, well, because I'm the only one left. But so I just had to speak to him very calmly and succinctly. And my husband has experience in the armed services, and he likes the thing to do. So it's like, right, okay, this is the situation. I need you to do this, this, and this. Get active. So off he went. He did his thing with my daughter, which was great. And then, so that there was that. And then he was going to the care staff, telling them, and people just sort of sprung into action. So after a few days of feeling like I was spiralling to an abyss, even though there were just a few, 2 care staff went and cleared a patient's room who'd recently died, made that room. I would do that for you, Charlotte. And
That was the room for you to stay in.
the room that I stayed in, and people are really good like that. I think when something's okay, we're at the bottom of a pit here. How do we get through this together? People just put out for you, and it's amazing what skill sets people have and don't utilise until a situation. And I saw a lot of real gifts come from people, real can-do things, which was quite awesome.
So you were living in the home, and the residents were in the home as well. Were they isolating in their rooms, or were they out and about? They were isolating in their rooms.
Yeah.
What could you hear from them?
Okay, so for the residents, we had one resident who was mobile. So they sort of resided in one particular space. The others were in their rooms. And as the staff depleted, we had to sort of prioritise nutrition, continence. And so they were seeing even less of us. That was really hard. And I would hear at night sometimes the person next door to my room crying at night. Where is everybody? That was quite distressing sometimes. But the fact that she was able to do that meant that she was actually okay. I know that sounds awful, as in she doesn't need end-of-life care or anything high maintenance. And then I might hear a voice, another resident swearing because they were on their own and that. And that was really, really hard. It was really hard knowing that because there weren't enough of us and we were having to prioritise by activities of living, things to survive, it did sort of come to the forefront of moral distress. The staff were feeling that they weren't physically able to give the care and resources they wanted to. And for me, knowing that I would have exhausted times, I was constantly afraid of making a mistake. Mm-hmm. And nursing home nurses, there's a lot of drugs management to do. So what I would do when I had quite sane, clear moments of sparks of energy, I would just get really organised. I'll be looking after my future self the whole time, organised, because some nights I didn't get any catnapping at all, because my intensive patient, who I would carry like a monitor with me all the time, so if I wasn't in the room with them, I could hear the breathing, because breathing was quite a high maintenance matter already with their admission.
Yes. From your statement, you did say you were having to take little naps in 30-minute snatches to keep listening out for people.
Yeah. I did think at one stage perhaps I should go and sleep in their room, but all the bleeps of their monitors and things would have kept me more awake, I think, than the breathing monitor, so I had to make that decision.
And you mentioned a moment ago about sort of planning in advance for yourself, I'm assuming in respect of caring for the residents. But you also did do some advance sort of planning, as it were, for yourself, didn't you?
Yes, I did.
Yes. You state in your statement that you were running through worst case scenarios in your head,
Yeah.
questioning what would happen if you collapsed and there was no one to take over from you. And you recall writing your final wishes on a card at 3 a.m.
Yes.
You also wrote a DNA CPR for yourself, didn't you?
Yes.
And you made sure that that card was placed in a prominent place.
Yes.
Now, there was a point where 2 carers were sent from a London agency to support, finally,
Yeah.
despite at the beginning you trying and calling
Yeah.
and failing to get support. How did that feel?
It was, yeah, it was awesome. So after having so many no's, because no one wants to, even if there were staff, no one wants to work in a infected hot zone. But yes, these 2 chaps arrive at the front door one morning, and I think I must have been going through one of my sort of high moments of like, woo. And when they arrived at 7 a.m. on a Sunday, just seeing them in there, coming, I just remember like, yay, come in. And so I put them onto day shifts. They did 12-hour day shifts so they could sleep at night. And I was so made up. They didn't have any care experience. So this was their first job, looking after other humans. So I was delighted to see them, but then there was that, oh no. but they did really well, and what they did bring was their presence. The things that humans so need. Of course, we need to have clean and food and stuff. They brought their presence, and one particular person had quite intensive, complex behavioural needs. She was a little monkey, but we loved her. And one of the guys who came to stay, I don't know how it happened, they just clicked. Different cultures, different ages, different everything. And having them about was, yeah. And it was like a hostel in the end. It became a real place of, aside the fatigue and the fear and stuff, it became a real place of love, and the sort of mixed faiths, mixed cultures, all living in this house together. It was strangely an awesome privilege. In amongst all that, so yeah.
Yes, in your statement you do say that it was a mixed experience.
Yes,
sort of
yeah, very much.
Experience, but also being a pleasant one. Sorry, but I'm going to have to turn to a bit of a harrowing experience for one quick second.
Absolutely.
You discuss living in the home and being alerted to a patient's deteriorating condition at 3 a.m. Mm-hmm. You state you went to assess him in his 90.
Yeah.
Because you were trying to get some sleep.
Yeah.
And you could see and hear COVID at work in the death rattle.
Yes.
What's the death rattle?
So the death rattle can be so when someone's in their final hours or breaths, if there's some fluid that hasn't been removed, or they got some, fluid here, in the breathing, you can hear the sound. It can be quite rasping, it can be quite loud, it can be quite distressing.
Just pause for a sec. I'm just wondering if we need this evidence. It must be very distressing for some people, and I don't think we need to go down here. It's obviously distressing for you, and I'm not surprised. So I think we'll leave that subject, please. Sure.
Okay.
Whilst you were working in the home, and in particular in the locked-in arrangements, did you have any access to sort of medical support, for example, GP or anything like that?
Yeah, fortunately, our local GP, they were aware of the situation. I made them aware. And I had what I can only call a hotline. So I had a phone number which bypassed the main inquiries that you call when you call your GP. It goes straight into this number. and then I could communicate what I needed, why and when, and they would and they would act on it, which would be really good. There was a really good professional relationship and trust of clinical judgment to be able to, if I could see that perhaps someone is heading down a certain way, I would get medications and things in place in a timely way, and they trusted my judgment.
And I understand that there were difficulties in getting residents transferred to hospital. In your witness statement, you mention a patient who was developing urosepsis.
Yes.
And you'd made a Category 2 999 call, which would usually have an average response time of 18 minutes.
Yeah.
But that there were 14 other Category 2 calls in the pipeline and only 2 or 3 ambulance staff available.
Yeah.
Was that a sort of regular experience in respect of trying to transfer residents from the care home to hospitals during the pandemic?
During in pandemic time, yeah.
You mentioned earlier about short staffing and moral distress. Moral distress, presumably, being there's not enough of you guys to be able to provide the care that you would want to. You were so concerned that you made a safeguarding alert, didn't you?
Yes, yeah.
What happened with that?
So, safeguards are raised by a person when there's a risk of abuse or neglect. And in this situation, it was by omission. So it's even when it's unintentional, we have a duty of care to report a situation where people are at risk of harm. And in this case, it was risk of harm by omission, because there weren't enough of us to ensure timely continence care, repositioning, nutrition, all the medication, everything that goes around good quality care. I called the local authority to raise a safeguard, but I did it on myself because what I was angst about is that because I was one person with so many things to do, that I could make a medication error, I could make any kind of error, but also the concern that not only myself, but also the wider perspective of the team is that I'm like a real quality care person, auditing and above and beyond, and to make this call on myself, and that I'm now having to declare that neglect is in progress through not wanting, through circumstance, was really difficult. And I've had a bit of a colourful relationship with safeguarding in the past. But what was really nice is that the officer who I spoke to was just awesome and really supportive and understanding, and said, "No, Charlotte, you can't do that to yourself, but you can for the home because of the situation." So that it was good to have that clear, but also quite unpleasant.
I've just got some last questions, and it's in respect of the sort of impact of the pandemic on you and other staff. But before I do that, sick pay. I understand that there was the announcement that you will have that there was going to be some infection control fund money, so that should be going into care homes to help tackle the pandemic, including providing PPE, but also ensuring that staff could get their normal pay if they had to be off sick with COVID or isolating. Did you receive any when you had to be off?
So the original address was when the Prime Minister said, rather than wait for day 5 to have sick pay, SSP, it will be from day 1. So that was relief. Then when I found out about ring-fenced money, infection control funding being issued from central to social, so to the care sector, one of the top main things on there was for staff to have full sick pay, not indefinitely, but for at least for those who have gone off with COVID-19 for at least the 10 days, which was the policy of isolating.
Did you receive it?
I didn't receive it, nor did anyone else in where I worked. I questioned it, and it enough to motivate me to have a conference call with my MP from the angle that this is happening in your constituency. There are these people, minimum wage, a lot of them, and the impact of them not having that full pay, even for 10 days, makes a huge difference. What was happening is that people were coming back to work as soon as that 10-day was over, even if they were really ill, they were coming back to work. A, because they need to eat, and B, because they don't want to let their comrades down, and they feel guilty, and that's a huge, that's a massive thing. Also with the sick pay, where did that money go? So part of this conversation with him was, I know it came to local authority, and then local authority deal it out to the care homes. So my angle for him was, well, where is it then? Is it local authority? Is it care homes? Where is this recommended money for these people? Because then it became such an issue between even management and staff, that after day 10, day 11, magic, you're really well and you can go back to work. And people who were still very ill, again, this is where misunderstanding comes, felt, they've been off for 10 days, so they'll be back tomorrow. But they were still ill. These people were ill, some people for a long time. Some staff died.
They did.
They died in service.
They did. And you gave up your nursing pin in October 2024, didn't you?
Yeah.
You unfortunately had contracted long COVID, and you've suffered from post-traumatic stress disorder as a result of your experience working during the pandemic.
Yes.
Yes. Thank you for answering my questions. My lady, I have no further questions.
Thank you very much indeed, Reverend Hardy. It's an extraordinary story and terrible thing to say, but I'm not surprised you got post-traumatic stress disorder, to be honest, after you went through what you went through. You looked towards the public gallery when you mentioned your husband. Has he come along with you?
He's here.
Well, I'm delighted that
There
you have
he
somebody here to make sure you get back, because it sounds as if you've come some distance, you said earlier.
We have.
Yeah, well, thank you very much indeed for taking the time. As I say, it was an extraordinary story and we needed to hear it.
Thank you for the opportunity. Thank you.
Safe journey home.
Thank you.
Very well, I shall return for a 10:30 start on Monday the 7th of July. Thank you.